Today, I'm speaking with Dr. Ali Madeeh Hashmi. He's the professor of psychiatry at King Edward. He also is the chair of psychiatry at King Edward, and he has the additional charge of being the professor of psychiatry at Pakistan Institute of Mental Health. I have a very long association of consulting with Dr. Hashmi with my own clients, and here's what I would say about his work. He's very conservative in his medication management, and he's a very rare psychiatrist who's supportive of counseling and therapy, and he dares to tell people on his prescription pad कि आप therapist के पास जाएं मेरे पास ना आए. Hi, Dr. Ashmi. Thank you for speaking with me today.
Hello, Omar. Wonderful to talk to you as always. It's been a long
Thank you,
time.
sir. Yes. Dr. Hashmi, the first thing I want to know from you is that how are you seeing mental health concerns in Pakistan? Is there some certain conditions that are being diagnosed more, or how's that landscape as you see it?
Before we start, Omar, just a very small correction. The big asylum, old asylum style hospital that I have additional charge of is the Punjab Institute of Mental Health, is what it's called. It's Pakistan's largest hospital, but that's what it's called. As far as the good thing is that mental health is finally, I wrote this in a newspaper article recently, mental health is finally having sort of a moment in Pakistan. Long overdue. We've been working, all of us have been working for this for a long, long time to get mental health center stage, to get people talking about mental health, to get mental health on media, to get people to be aware of these conditions. So all of that is a good thing. And I think all of us have been working for a long time and working very hard to make that happen. One of the consequences of that is that mental health conditions are being diagnosed more. People are coming to clinicians more to get help for mental health conditions, and it's a usual mix: depression, anxiety, trauma-related issues, substance abuse issues. Some of the more severe conditions, bipolar disorder, schizophrenia, things of that sort. I'm also an advisor to Alzheimer's Pakistan, and I've done quite a bit of work with them. And so that's another, and it's an area of interest of mine, psychiatric illness in old age, so dementia and psychiatric illness of old age, Alzheimer's disease. So that's also becoming, more sort of mainstream awareness efforts and advocacy and all that. So it's the same, I would say it's the same sort of mix of conditions that you see all across the world. In our part of the world, that's complicated by poverty and unemployment and political unrest and law enforcement issues and terrorism and all of those things, which are in some ways now with climate change, floods, all of that. But of course, the conditions are the same as the mental health professionals talk about: depressive disorders, anxiety disorders, substance abuse issues, all of that. The good thing is, there's more of them are coming to attention. I think there's a mixture of perhaps we've always had a very high prevalence of mental health disorders in our part of the world. I think it's just not been recognized before as much. So it's many of the same conditions, more being talked about, more being addressed, which is a good thing.
Okay. With a lot of even my own clients, sometimes they have that misconception that if we may take psychiatric medication, there'll be severe side effects and we'll be hooked onto it. A lot of times they have impressions from their parents' generation that they were on certain medications all their lives, so they're very hesitant. So has something changed with that? Are medications safer now?
Well, I'm not sure if medications as such are safer now. I think that's been the case for a couple of decades, really, ever since the what we call the serotonin specific reuptake inhibitors came out, starting really in the late 80s with Prozac and then all that generation of drugs. So those medications tend to be a little bit less problematic at the front end in terms of side effects. That was one of the reasons that they became so popular in the West, and now that they are extremely widely used in Pakistan as well. Although interestingly, you may be aware, this is an old US study. I need to look up, recent studies, but an old study in the US quoted the fact that about 80% of psychiatric medications were prescribed by non-psychiatrists in the US. And in Pakistan, we have very poor local data on various different things, including this particular issue. But anecdotally, I can tell you that in my practice, I see a lot of antidepressant medications, anxiety medications being prescribed by physicians,
Absolutely.
gastroenterologists,
Yeah.
cardiologists, all kinds of specialties, all kinds of, even neurosurgeons. Neurosurgeons
Yeah.
tend to do a lot of, because I suppose because they feel comfortable in the general area of the brain. So,
Yeah.
so a lot of psychiatric
I can
medications
confirm the
being
same.
used,
I hear
yeah,
the same.
being used by a lot of non-psychiatrists,
Mm, mm,
which tends to be quite problematic. Psychiatric medications are they, there may be impression that they're
mm,
easy to use and they're not very, not, sort of harmless, but it's not true. Psychiatric medications can become extremely problematic if used inappropriately. The
mm,
one reason we are in general a medication averse culture, as
mm,
opposed to a culture like the US, for good reason in psychiatry, because if these medications are dosed inappropriately, I mean, these medications are meant to act on the brain. That's what they're
uh-huh,
supposed to do. And if they're not dosed appropriately, then you're going to have problems with concentration and thinking. And,
mm,
a common complaint, I wrote about this in a newspaper a couple of years ago. People complain that psychiatric medications make you sleepy and hard to
mm,
function and all that. And yeah, that does tend to happen if they are used by someone who doesn't know what they're doing, if they're dosed carelessly, if they are used inappropriately, if they're used for conditions in which they shouldn't be used. So
mm,
they're not benign sort of happy pills. They can be very problematic. They can also be extremely helpful if used carefully.
mm,
If used judiciously by someone who's
mm,
qualified, who knows what they're doing. I've often felt that perhaps I tend to be a little bit, and I know my peers in Pakistan, psychiatrists,
mm,
uh, uh, perhaps they feel that I'm too conservative with medications, but I
mm,
think with the general push towards sort of the biological approach of treating all kinds of mental health conditions, where a sort of a pill for everything, I
mhm,
think there's no harm in trying to balance that out by saying, you can use the medication when it's indicated, but let's bring in psychological treatments. Let's
mm.
bring in other kinds of treatments. And
Yeah.
this is not even to talk about, social issues, poverty and, lack of
Mm,
opportunity and, violence against women and all of these things, which really are not the purview of psychiatrists and not certainly
mm,
not treatable with medications. I mean, that you need to work on other levels in society to address some of
mm.
those issues. So medications are very helpful when used appropriately, when used judiciously, when used when needed. But they can be psychiatric medication can be very problematic
That's a very
if overused. Yeah.
That's a very, very useful message. I want to connect this with that general sense. A lot of, I would like to say, most of our households have some household brand name of a Lexotanil or Xanax, which they will pop whenever, I don't know, there's conflict at home or there's something else. What would you say to those people? I mean, that sense, which is it's not only specialist care, that a physician shouldn't just be suggesting psychiatric
Well, I would
medication.
I would say I would say it's a failure of oversight of regulation, first of
Mm,
all. So, all across the civilized world, probably in Australia,
mm,
certainly in the US where I trained, you can't just walk into a pharmacy and ask for a medication
mhm,
unless it's been prescribed by a doctor or a properly qualified professional. That's a basic principle of medical practice, because medications can be problematic. They can cause side effects and all that.
mm,
I think uh, uh, one reason that you have control over that, for instance, in a country like the US, where I've trained,
mm,
was you have third-party payers, insurance companies are paying, and in England, I think that if another person is paying, then they're going to have some control over what's being done. In
okay.
Pakistan, that's not the case. It's a sort of a personal transaction between the doctor. Yeah, we have a fee for service model where the
Mm,
person comes in, they pay my fee, and then they get the care, they walk in the pharmacy. But really, we have a significant uh, uh, gap in our regulation of medical services, in terms of
mm,
no prescription requirement for medications to be prescribed by pharmacies, or you don't need a prescription, which needs to be enforced. I don't know what the law says about that, but pretty much
mm,
anybody can walk in any pharmacy and get any medication
mm.
that they need, which can become a real problem. And I think mental health professionals and even the lay public and educated people can do their part by at least telling other people, don't do that. If you
Yeah.
if you you know if you're unwell, seek the
Mm,
advice of a medical professional. Let them tell you what you need.
mm,
Don't just go to a pharmacy and let the guy there who's not a doctor, who's not a healthcare professional,
mm,
hand you whatever they think is necessary, which you wouldn't have to deal with in Australia
mm.
or America or Canada, which are
Right.
much. better
I can
developed
see how
regulatory systems.
controlled substances can then be somewhat normalized and they can just be used
Yes,
like by the
absolutely.
doctor. What would be those conditions? What would be those psychiatric conditions where medication is necessary? In my experience, at least with OCD, for example, I've been highly unsuccessful in working without medication. So, what are some of the other conditions where medication may be
Yeah,
necessary?
so it's the research says that there are multiple conditions where medication. So if you want to break it down into three tiers where medication, conditions where medication is necessary, you can't really work without medication.
Mm,
Conditions where medication is helpful, and conditions where medication can be avoided. So more severe conditions like obsessive compulsive disorder, all the research says that without medication, OCD most likely will not improve a whole lot unless it's very mild.
mm,
You've got conditions like schizophrenia, you've got conditions like psychosis because of other things, substance-induced psychosis, things of that
mm,
sort. You've got acute manic episodes.
mm,
Just recently, this is, change of season causes mood symptoms, which can lead to mania. So this is mania season in Pakistan. Unfortunately, I've
mm,
been here for going on
mm,
13 years now. So those
mm,
repeated cycles. We have another spike in February, March when the weather warms up.
mm,
Just recently, got a call. It happens every day. Panicky call from a family. A young man who's completely psychotic, has not slept for days. Thinks he's a prophet and wants to, all of this, and eventually ended up breaking things in the house and going out of control, having to be. So these are conditions where medications cannot be avoided. Medication shouldn't be avoided. In fact, the earlier you jump in with medications,
mm,
the better, because you can then abort the acute condition and save
mm,
the person and their family a lot of grief.
mm,
Conditions which are more acute that may require medication, but perhaps you can be. So you've got things like depression, you've got things like panic attacks, things of that sort. And in that case, usually you need to make a judgment call about whether you should start medication right away, whether
mm,
you should wait and give therapy a chance to work, which becomes its own complication because of the lack of qualified therapists, access to qualified therapists. Once
mm,
again, that big obstacle, the ability for people to pay for good quality therapy services, the
mm,
fact that therapy is more time intensive, they have to invest the time, and people tend to avoid sort of putting in the time. They would rather just take the pill. But
mm,
those conditions, depression, anxiety, all of those things which are more
mm,
severe, and that's research proven also for severe depression, severe anxiety, medication is indicated first line. And then for anything less than that, mild to moderate anxiety, depression, things
mm,
of that sort, it's always psychotherapy which is indicated first line, at least to
mm,
begin with. But what I tend to do to make it easier for myself is I'll just ask the other person, the person who's come for help, uh, tell me your preference. And some people say, doctor, we don't want to talk to, we don't want this talking thing. Just give us a
mm,
medicine. And then some people say, I do not want to take medicine. Give me another solution. So that makes my job easier because
mm,
I've got, good, good quality psychologists, therapists who I collaborate with. And
mm,
if they want to do that, fine, let's go ahead and try that. And if that works, fine. You don't need to come back to see me. You're done, no problem. If they
mm,
say, let me take medication now, it becomes a problem. Is I know likely without good regular psychotherapy, they will not achieve long lasting symptom improvement. So I'll give them the medication because that's what they're asking for. So
mm,
I can't not tell you, and I can't not keep telling you to go and do the psychotherapy and get the help you need there. In
mm,
addition to whatever I can do with medication,
mm.
and if you keep resisting, if you keep saying, I don't want to be in therapy, I'll keep telling you, hey, this is what I'm doing is only half the work, and you say that's
Uh,
okay, then I have a clear conscience, and I don't have to feel
That's a very
bad about
important
because I've
factor.
done my
The
part.
patient
Right,
preferences,
right.
how they look at that.
Good. Yeah,
I
yeah.
want to check with you about treatment resistant conditions, or a few people asked about treatment resistant depression. That where are we with that? Especially in Pakistan, where there might be a delay in more recent advances to make it to Pakistan. So where are
Yeah,
we?
I have a, we have, there's a couple of factors.
Mm,
In terms of treatment resistance, you need to make sure that that's actually what it is. So, do they have the correct diagnosis?
mm,
Have they had appropriate trials of the recommended medications for long enough? In other words, is it actually treatment resistance, or is
mm,
it because they have not been properly diagnosed, that they've not had adequate trial? Because treatment resistance in the work that we do in psychiatry is defined in a certain way by failure to respond to a certain number of medication for a certain period of time, all that. So there's a
Mm-hmm.
specific evidence-based definition of treatment resistance. Uh, and with the lethal illness nowadays, which is called Googleitis. That's what I call it, Googleitis. Sometimes people just come in and be sort of
Yeah.
self-diagnosed. That's what
Mm-hmm.
that's what we have, and it's like, well,
Mm-hmm.
wait a minute, can we talk about this? Because
Yeah.
I think it's a wonderful thing that people have access to healthcare information and they can take charge of their own condition and of their own recovery. Uh, but yet, I mean, you can't really replace a medical degree or years of experience with a Google search. I mean, it can't be done. This is not to downplay the understanding that a person with lived experience, that's the current term,
Mm-hmm. Mm-hmm. Mm-hmm.
has of their own illness. Yes, so I absolutely am on board with the fact that I can never understand depression as well as a person with lived experience of depression. But you can't diagnose psychiatric illness, especially complex psychiatric. You can't find treatments on Google
Mm-hmm.
by bypassing a qualified medical professional. This is a whole other debate. Let me say a quick word about you had mentioned. So options for, or more advanced options,
Yeah.
scientifically advanced options for, uh, let's say, treatment-resistant depression, such as ECT or repetitive transcranial magnetic stimulation or ketamine treatment, are
Mm-hmm.
limited in Pakistan. The availability of those is limited. People who are qualified to administer those are limited. They are available, but they're a little bit hard to find. Um, so there's that. I think
Are
it would be
those
good
protective,
to have
or
those
are there
treatments available.
times when you refer these services to some of your patients?
I have not referred someone for RTMS for a while because there's one person who does it in Lahore, and I had sent a few people. It's very, very expensive. So
Mm-hmm.
in the US also it's very expensive. Pakistan not so much, but still you have to pay for each treatment option, and quickly becomes a burden on most people.
Mm-hmm.
ECT is actually available at Punjab Institute of Mental Health. We do that there. Have not referred anybody recently. Ketamine is not been officially approved in Pakistan. Not available really at any qualified physician site. So those treatments are limited. And there are questions, for example, about ketamine. There's still questions about the sustainability of the treatment, the sustainability of the recovery, whether whether it's going to create more problems down the road in terms of ketamine being an abusable substance, dependence, things of that sort. So, at heart, I guess I'm a psychologist stuck in a psychiatrist's body. I don't really want to sort of jump into the biological aspect and pretend that the biological treatment will fix what's wrong with the person's life. I think the biological solutions are a wonderful tool that we have at our disposal, as long as we don't give people the impression that this is the solution to their life's problem, their relationship, their marriage, their job, all of those things. So there's that whole aspect also. But those things, the marriage, the job, society at large, those things are hard to fix. Those things are very, very difficult to fix and even more difficult to accept. So it's no wonder that people tend to gravitate towards the biological treatments as an alternative to that. You had mentioned whether psychedelics are going to be sort of the next frontier. There's a lot of talk about that in the US and all that. And I sort of look at it the same lens. I mean, I think those can be wonderful tools for really, in a way, bypassing months or maybe years of therapy to get to the root of the problem. But are we trying to find a shortcut solution to something that doesn't have a shortcut solution? I don't know. And then, of course, are they going to create more problems in an environment in an environment like Pakistan where there's no regulation, no laws to speak of, no oversight? We're using these very strong sort of mind-altering substances. Are we going to create more problems than we fix? And that, so it's, all of these are questions that need to be considered before we jump into these sort of modern, what seems like fantastic treatments. But 50 years ago, lobotomy seemed like a fantastic treatment.
Mm-hmm.
60 years ago, insulin coma seemed like a fantastic treatment.
Mm-hmm.
So I want to wait and see before when we have, if we once we have more evidence in terms of recommending these to more people, rather than recommending them as a quick fix or as something that's new and wonderful, and then we find out 10 years later that we created more problems than we solved. So there is that aspect also.
That's one of the things that I most admire about your consultation process, that you look at a lot of these mental health concerns in their complexity and depth rather than in a very limited trigger happy manner. So I wanted to know
Umar,
with that.
you mentioned earlier about me being a therapist friendly or a psychologist. Somebody
Mm,
paid me a
mm,
very nice compliment in Lahore at a
mm,
seminar. There's a whole room
mm,
full of psychologists, senior psychologists. Oh, Dr. Hashmi is a very psychologist friendly psychiatrist. And my question is, why am I the only one? What is that
mm,
all about? Because my expertise, the medical, the biological part,
mm,
is one domain, and your expertise, the psychotherapy, psychological part, is another domain, and we need both of those together in order to help the people that we're trying to help. So what is this? What is this thing about? It's you against me, or what? I've
mm,
always found
mm.
this rather silly. I trained in the U.S., you trained in the U.S. Psychologists and psychiatrists work together along with
Oh,
social
absolutely.
workers and substance abuse
Yeah.
counselors. It's a team approach to get the best possible outcome for the person we're trying to help. And in
Mm,
Pakistan, we have these, little petty turf issues.
yeah.
People don't want to work together, which really,
Yeah.
which tends to harm the people we're trying to help.
Mm,
That's
mm,
just silly. I mean, I've never understood that, and I've still worked on that. I've tried a long,
mm,
tried to, get everybody on the same page, because I don't have the expertise of psychologists, and you don't have my expertise in medication. So why don't we work together to try and help the people that we're trying to help? Why aren't other psychiatrists doing this? This is what I want to know. I mean, why am I the only psychologist and the
It
psychiatrist?
doesn't
Isn't that
seem like
silly?
in the last 10 years in Lahore that has changed much. I mean, I've seen my clients go to you and another psychiatrist, and there's a very, very stark difference in the prescription that you've given and someone else might have given those 8 or 10 things on that same piece of paper versus you're either saying go back to therapy or something that might be necessary for them. So I wanted to know, which is that I
Mhm.
may not have a lot of hope with those 8, 10, 15 people who are prominently working in Lahore, but the next generation of psychiatrists that you're training, and you're very ingrained in that consultative process even with the government. What hope do you have here? What all is even happening there?
It's interesting you asked that, Umar. I was just thinking about that. In fact, the biomedical model of psychiatry is not just a Pakistan. It's very much a global model, originating, of course, uh, uh, I suppose starting from the U.S., but prevalent in many ways across the globe, and it goes back several decades, really since the beginning of the psychopharmacology era in the 1950s. You asked about my trainees in Pakistan. We have uh, a sort of a personality driven culture. So
Mhm.
what tends to happen is, despite my repeated pleas to my trainees, they'll do it the way I'm doing it rather than following, sort of the evidence and so on, which is fine because I'm doing it this way and that's what I'm teaching to them also. And I think it does help. I mean, the people who I've mentored and taught, who are now at a consultant level, or who are themselves teachers now, uh, tend to follow that model to the extent possible within the limitations of what we do. So one reason that psychiatrists don't refer to psychologists as much in Pakistan is because of lack of high quality psychological services as well. I mean, that's a problem. We
Yeah.
have thousands, tens of thousands of psychologists being churned out of colleges and universities with very little oversight on their training, on what they know, what they don't know. They all have degrees, they are supposedly. So, we have a completely imbalanced educational system here also. So that's part of the problem as well. People like you and people who are qualified and ethical and educated and know what they're doing tend to get very busy very quickly, and then they sort of have to. And of course your work is not volume driven like mine is. You have to
Mm,
parse out your time in terms of how you distribute it. So
mm,
that's part of the problem. I would like to think that I'm having an impact on sort of the prescribing habits and the way of practicing of sort of the younger generation of psychiatrists. I
mm,
hope so. I mean, it's anecdote. I have not done a study on it.
mm,
Maybe I should. Maybe that'll help. What
mm,
I see in people who work with me and people whose prescriptions I see, I'm hopeful. I'm encouraged that they're doing it the way it should be done, paying attention to the medical part, the medication part, but also paying attention to psychological therapies and family work and things of that sort. I'm hopeful, but time will tell. Let's see.
So I have a last question about your role as a consultant to the government when you've been a part of the Mental Health Act. Can you say a bit more about that? What can we expect to unfold in the years ahead, especially when it comes to ethics? Is there some work being done with that?
So yes, so the Mental Health Act is really only in force, since 2018, since devolution, since some of the federal powers were devolved to the provincial governments. The mental health legislation also sent back to the provincial governments. It has been passed in Sindh, and there is an active mental health authority in Sindh, although from what I've heard from friends in Sindh, not too terribly active, but they meet and they try to work on it. In Punjab, we have a mental health act from 2014. We amended it, we rewrote it. I worked with the last government to try and get it passed at the provincial level, but before that could be done, the government changed, and so it's sort of still in limbo. So we're still under the Mental Health Act of 2014. The federal government is working on the sort of a mental health act for the Islamabad Capital Territory, which I also helped work on that in the last government. So as far as mental health legislation, there is some on the books, and some of it has been formally approved by the legislative bodies. For instance, in Sindh, but mental health legislation is a very complex process because you've got, in addition to mental health personnel, you need to involve judiciary, law enforcement,
Mhm,
police. There's all kinds of things like, property rights, taking care of people who become disabled due to mental illness, so on and so forth.
mhm,
So the rules of that, rules of how that will be applied, and then the bodies that need to be created, which will actually enforce, parts of that legislation, it don't really exist yet. I mean, it's very much in its infancy. Punjab Institute of Mental Health, which is the big hospital which I'm helping sort of try and reform in collaboration with Punjab government, is the main center for forensic psychiatry. So legal cases,
mhm,
including sort of relatively benign ones such as pension cases and disability cases, all the way to criminal murder cases related to mental health, so people not guilty by reason of insanity, and blasphemy cases, which people have mental illness and get accused of blasphemy and have death sentences, prisoners on death row. All of those get referred and examined at Punjab Institute of Mental Health. So we are the main forensic center for all of Punjab. So I'm also sort of learning more about the mental health law process in Pakistan. And it's still very much in its formative stages. We're still very much for instance, we don't have a single forensic psychiatrist in the entire country who's trained in forensic psychiatry. So we are working now
mhm,
we have I have a good friend in the University of Toronto. We're developing some courses. I would love to learn more about that, but I've been told that I can't go, I can't take a year off and go, learn about it. They're like, whatever you want to do, you need to do it here because you can't leave. Like, okay. So, so we just, this past July, we started a child psychiatry fellowship at King Edward, and we are
mhm,
one of three centers in Pakistan which are developing child psychiatry services in Pakistan. So we're happy that that's the first subspecialty in psychiatry that we're developing. But forensic services,
mhm,
mental health legislation, it's a whole other area that needs to be worked on. Expert witnesses and court cases and so on and so forth.
mhm,
We are working on it sort of piecemeal, but the legislation, even though it's on the books, is not enforced yet. It's not in power yet. We don't have the bodies to enforce it. We keep trying to educate, our judges and our judiciary and our lawyers and our police and all of these kind of things. But it's quite an uphill task. Of course, with the awareness of mental health and the general focus on mental health, and recently some landmark decisions on
mhm,
mental illness and the law, such as the schizophrenia case that was in the
mhm,
news,
mhm,
and then some terrible tragedies like the Noor Muqaddam case recently, which is sort of a forensic case that has
mhm,
brought the spotlight on this area of mental health and the law.
yeah.
And so so the legal authorities, the judges, the police, the government, they're also very much sensitized now to this issue. So we're being asked to step in and try and work on that. But like everything else in Pakistan, it's sort of chaotic. It's kind of a mishmash. There's different agencies, different laws,
Mhm,
different regulations. We have people who are very sympathetic to the idea. We have people who sort of are resistant to the idea. So it's an uphill task, but we keep working on it. It's probably going to take a few more years to
Even
get it
coming
straightened
to
out.
this, it's so many moving pieces, and I just feel that being a one-person army sometimes is a big, it's a very, very big role to
It
have.
it can get overwhelming at times, but my psychologist friends in Lahore keep helping me out. They're like, just call us when you need. We'll sit down. We'll have a chat. I'm like, okay.
All right. Thank you so much for talking to me. This has been very rich, and I'm very glad to catch up with you after quite a while. Thank you so much for talking to me, Dr.
Well,
Hashmi.
it's always a pleasure. Thank
Okay.
you.